Good day, everyone. Today I'll be giving you a brief outline on musculoskeletal tumors. This is actually a very hard topic and a lengthy topic, but I tried to compress it as much as I can. So today, initially or last year, I divided musculoskeletal tumors into two lectures, but since we don't have any time to do that anymore, I just picked out the latter lecture. And so this is what I'll be discussing with you today. So for musculoskeletal tumors, we need to have what we call a staging system. So for these types of tumors, what we use is the Enneking staging system. So it's used for both benign tumors and malignant tumors. So Enneking system composes of three things: the tumor grade, which is based on the histology of the tumor, the size of the tumor, as well as the presence of any metastasis. So in order to describe these each, for the Enneking staging, tumor grade is divided into three. We have the G0, G1, and G2. We have G0 for benign lesion, G1 for low-grade malignancy, and G2 for high-grade malignancy. So histologically, you would see more of atypical cells for high-grade malignancy. For tumor site, we have T0 to T2. So it's based on compartments. So if the tumor is filled with or has a capsule and is within an anatomic compartment, it's usually graded as a T0. But when it doesn't have a capsule, or when it's not confined within a capsule, but still within a single anatomic compartment, it's T1. And when it crosses beyond its anatomic compartment, it's T2. So for metastasis, we only have two. We have M0 and M1. Whenever we have a presence of regional or distant metastasis, then that tumor is actually an M1 tumor. And you already have a stage 4 tumor. Now, as you can see, we have the following grading systems based initially on the previous table. So we have 1A, 1B, 2A, 2B, and 3. So whenever a tumor has two or more compartments, it becomes a B. So whenever a tumor is, for example, T2, then you would consider it a B. And whenever a tumor metastasizes, then you already consider it a 3. Whether or not it's a G0 up to G2 or a T1 up to T2. For the benign staging, we have the following. So we have the latent, active, and aggressive. So latent tumors, they're usually seen just with regular X-rays. So they don't have any symptoms and they have relatively slow growth. For active, so these patients usually present with symptoms. Sometimes the patients have a pathological fracture or mechanical dysfunction. And then for aggressive, you usually see patients with a rapid growth and tender with signs and symptoms. So the first or the initial thing that we use to evaluate tumors would be radiographs. So it gives us an educated guess on what the tumor is, because some tumors have a certain characteristic on radiographs. So there are 7 X-ray questions that we usually look for in bone tumors. Number one question would be where is the tumor? Number two, how large is the tumor? Number three would be what is the tumor doing to the bone? Number four, what is the bone doing to the tumor? Number five, what is the matrix? Number six, is there any cortical break? And number seven, is there any presence of a soft tissue mass? So these are the common tumors by site involved. Uh, so I divided them into two. One would be less than 30 years old, and the other would be more than 30 years old. we'll be discussing each of these as we go along. So as you can see, we also have different tumors that are common by age. Uh, Although at 1 to 5 years old, osteomyelitis is actually not a tumor. And but when the patient reaches greater than 40 years old, we always consider metastasis as the most common tumor. So initially we have presumptive diagnosis of what the tumor is, but in order to have definitive diagnosis, then we confirm it by using biopsy. So we can either do intralesional, marginal resection, wide resection, or radical resection depending on the grade of the tumor. Usually intralesional is for those benign tumors. Or what we mean by marginal excision is when we excise the tumor through the reactive zone, or what we call the capsule. And then wide excision is when we have 2 or 3 centimeters cuff of normal tissue excised along with the tumor. And for radical resection, that already involves the entire anatomical compartment or even the limb. So always have two options for tumors. It's one is either limb salvage, the other would be amputation or disarticulation. So our primary goal would be to cure the disease and preserve limb function as much as we can. So for limb salvage, what we do would be wide excision. So we still have a cuff of normal tissue or bone, and we combine this with adjuvant or neoadjuvant therapy. In order to the prerequisites for limb salvage are the following. One would be that the tumor is in the extremity or in the appendicular skeleton. Number two would be that there are adequate margins and it's amenable to surgery. Another would be there's only a moderate soft tissue mass, an intact neurovascular bundle, so the patient must have no metastasis present, or the patient is amenable to curative treatment. The patient is in good health and there are adequate family financial resources, because limb salvage has a typically longer treatment period compared to amputation or disarticulation. So for adjuvant therapy may be given before surgery. We call that neoadjuvant therapy. So it helps us decrease the tumor size prior to surgery. However, the problems that are involved usually, for example, would be for preoperative radiation. It increases wound healing problems. So adjuvant therapy is given after surgery to kill microscopic tumor around the site, uh, skip and distant metastasis. So it can either be chemotherapy or radiation therapy. Now these are the recommendations based on the tumor stage. For benign tumors, you can do just intralesional excision or curettage. For stage 2 tumors, or those tumors which are more aggressive with the fracture involvement, we usually do marginal excision or just the capsule around it. We can leave a bit of tumor tissue there. For stage 3, we do wide excision or marginal excision with adjuvant therapy. Now for malignant tumors, we have a different recommendation. All of them involve wide excision, and starting at stage 1B, you already have neoadjuvant or adjuvant therapy. For stage 2, you already do radical excision or marginal excision with neoadjuvant or adjuvant therapy. And finally, for stage 3, you always do radical excision with adjuvant therapy or palliative resection. So these are the common benign bone tumors. So we have the latent tumor, which is discovered by accident. We have the active tumor, which is noted with a pathologic fracture usually, or some mechanical dysfunction. And you also have the aggressive tumors, which are rapid growing and with signs and symptoms. On radiographs, you would usually see patients with a cortical break as well as soft tissue masses in aggressive types of tumor. So for the examples, for latent, you usually see UBC or unicameral bone cyst, a bone island or metaphyseal fibrous defect. For active, usually would usually have chondroblastoma. For aggressive, we have the GCT or giant cell tumors and chondroblastoma. So these are examples of common benign tumors. Number one is a bone island. So it's a normal tissue or normal bone tissue in an abnormal location. So as you can see in the radiograph, you have cortical bone inside the medullary canal. So these are usually incidental findings and we can leave them alone. The next one would be osteoid osteoma. It's a picture of or radiograph of the patient's um, humerus. These are usually painful at night and can be treated with NSAIDs. So it's one of the characteristics of osteoid osteoma. So on X-ray, it's a lucent nidus surrounded by sclerotic bone. They can be left alone, but when they're symptomatic, you can do en-bloc excision, radiofrequency ablation, or CT scan guided needle ablation. Next, on the patient's calcaneus, you would see here unicameral bone cyst. So, unicameral bone cyst is a transient failure of ossification of the physeal cartilage, and here we have cyst formation. So, they're usually discovered after a pathologic fracture, and on x rays, you can see a radiolucent structure with distinct borders. So, sometimes it actually expands the cortex, and it's usually managed with just in traditional curettage with bone grafting, especially for example in the proximal femur. Now for this expansile mass on the distal ulna, this is an example of an aneurysmal bone cyst. So aneurysm, it's a blood-filled intramedullary lesion. So it's eccentric in location, it's expansile, so it expands the borders, typical borders of the cortex, and is also lytic. So the usual management would be intralesional curettage with bone grafting. Another would be fibrous dysplasia. Usually it softens up the bone. So the bone, normal bone is replaced with fibrous tissue and metaplastic bone, leading to a weakness in the extremity. You'd see them usually in the proximal femur. Here you have what we term as the shepherd's crook deformity. So it can be multifocal, so you sometimes see them in the spine as well and in the humerus. So in the spine, you have endosteal scalloping as well as ground glass matrix on radiograph. So the management is usually intralesional curettage with bone grafting and fixation to prevent fractures. So for benign bone tumors, usually they have distinct borders on radiograph and they do not have any invasion of the local tissues as well as there are no evidence of metastasis. Now, for the common malignant bone tumors, this one is an osteosarcoma. So it's the most common primary malignant bone tumor. So the most common bone tumor is of course multiple myeloma. Uh, the most common tumor in the bone is metastasis. But for the most common primary malignant bone tumor, we have osteosarcoma. So it has two peaks in the young and usually in the old with Paget's disease or the patient has received radiotherapy. So its characteristics are that it's very aggressive. It has permittive borders and it can occur in the metaphysis or on the surface of bone. So we have different variants, the high-grade telangiectatic, high-grade surface, high-grade small cell, extraskeletal, low-grade surface, low-grade intraosseous, and the porous shell. Now, next one we have the Ewing sarcoma, which is a very aggressive malignant round cell tumor, usually occurring on the second to third decade of life. So they're relatively rare compared to osteosarcoma, and they're usually found in the diaphysis and metaphysis of the bone. So the characteristic you would usually see is a lytic lesion with extensive bone destruction and permeative borders. So its characteristic findings, you'd usually see a Codman's triangle, onion peeling, or the sunburst appearance. Next, we have the chondrosarcoma. So it's a cartilage-forming tumor that may occur primarily or secondarily after a pre-existing benign tumor. So it can occur after having a patient with an osteochondroma. It can actually develop into a chondrosarcoma if the um, cartilage in the lesion is big enough. It's usually common in the pelvis and ends in the long bones, and it occurs at the fourth decade of life. So it has poor prognosis because it's resistant to both chemotherapy and radiotherapy. Now, for soft tissue tumors, uh, there are some soft tissue tumors that are easy to diagnose because of MRI. They have characteristic findings on MRI. These are lipomas, hemangiomas, angiolipomas, myxomas, and synovial cysts. So whenever we have any evidence of lymphadenopathy or distant metastasis, then we consider malignancy. Benign masses usually are soft compared to malignant masses. And of course, we usually do biopsy after careful preoperative preparation. Now, in order to rule out any metastasis, the patient should be staged with a bone scan and chest CT scan to facilitate treatment. So these are the common soft tissue tumors. On the left side, we have the benign ones, while on the right side, we have the malignant ones. So whenever you see a sarcoma in the name of a tumor, it means that the tumor is a malignant tumor. So for lipoma, rhabdomyoma, leiomyoma, hemangioma, and fibromatosis, these are usually benign tumors. So that's the end. Thank you.